Good afternoon, everyone. So, there are very few queries that has come across me. One is the first question is about 35-year-old male who is presented to the emergency room with a history of headache for 10 days. He's got joint pains mainly in the hips, elbow, and wrist, and multiple convulsions and respiratory distress. His GCS is given 10 by 15. He is a bit hypotensive, blood pressure 85 by 60. And now you have twos coming your way that he has got severe purpuric spots. He's icteric. Laboratory results show hemoglobin urea, blood sugar of 40 milligram per deciliter. So obviously he is a hypoglycemic. Lactate of 4, urea of more than 20 milligram per gl. And he has a recent travel history to a malaria endemic area. Which of the following is true in investigation in this condition? So first of all, let me congratulate you, the guy who has made this question. But usually what will happen is they may not give you malaria endemic area because they expect when it comes about fever in returning traveler. This is how the topic is given in headache. So they expect you to know areas which are having malaria, Kala Azar, and all these diseases as endemicity. So probably when they talk about traveling to all these countries, and similarly they want you to know which are the areas where certain kind of STDs are prevalent. For example, most of the times when they talk about tropical countries, that the clue is about Leishmania donovani or gonorrhea. So let's come back to this question. It is like the first statement is severe complications do not occur in patients with low parasite counts on smear examination. This is false because the parasite load has not much to do with complications, or rather absence of complications. It is a known fact even with a low parasite load you can have higher complications. Second is Plasmodium vivax is most common form of cerebral malaria. Obviously that is also not true. Third is rapid diagnostic test detect malarial antigen. Yeah, whenever it is rapid diagnostic test, most of the time they're antigen detection test, and PCR tests are less sensitive than microscopy. This is also true because as of now, even today, the gold standard is thick and tell film on microscopy, and obviously it also allows you to staging of the disease, and the schistocyte index can also tell you if and how my patient is responding to that treatment. So fever in returning traveler is slowly turning out to be subset from where you will definitely get one or two questions, or infection returning traveler if you want to put it that way. And the common infections they try to cover there are malaria, and as I said earlier, they also try to cover sleeping sickness, a bit of Kala Azar, diarrheas, and STDs, invasive respiratory. So apart from knowing the geographical area where the endemicity is, second question can be the drug of choice. And usually,
Dr. Niraj, if possible, your video, if you on your video,
just give me a moment. There are some signal issues today. Rain like hell. So just a moment. Let me see if that can happen.
okay, sir. Okay, sir. Sir, continue.
Okay. So let me just try. Any better?
Sir. Yes, sir.
Okay. So when we talk about this is the situation that we are mostly dealing with, and the topic I was talking about is choice of antibiotics, and this is probably gets slightly difficult for us because our microbiota is slightly different, and so is our choice of antibiotics. So you should be knowing that most of the time the simplest of the antibiotics are the choices, and finally you also must know the areas where you have mostly Plasmodium falciparum, if the resistant variety. Otherwise the treatment what we use here most of the times is slightly different. So in terms of when it comes to Other things that they try to talk about is hepatitis E or viral hepatitis, which is primarily waterborne. And usually you will again get a clue about the endemicity and the presentation as compared to hepatitis A. And they will also talk about a bit of mortality data when it comes to hepatitis A. Probably if there is a question down, we'll discuss that. And the second question is about a 50-year-old gentleman. He's admitted to ICU for community-acquired pneumonia. He's treated with ceftriaxone and azithromycin. So usually you will find second or third generation cephalosporin or beta-lactamase, and one of the drugs would be there to cover for atypical pneumonia. This is the standard way how they treat. 5 days later, he develops abdominal distension, tenderness, and diarrhea. He is hypotensive with oliguria and W's white cell count of 36,000 cells. And a creatinine of 3 mg per dl. He tests positive for Clostridium difficile. All of the followings are true about this organism and its treatment except. So, this is a pretty straightforward question. The first choice is in the critical area, it is caused by almost any broad spectrum antibiotic. So, although